Hey. Hello, everyone. I think I can see our attendees have joined in now. So thank you so much for joining us. My name is Indu. I'm a clinical fellow in CNS Radiation Oncology at Stanford University. I'm delighted to kick off this session for 2024 with the Rover ACRO collaboration for these webinar series on different disease site groups within radiation oncology, as well as novel technologies and treatment modalities. Today's session will focus on CNS treatment modalities, including some standard of care, but also some emerging technologies in this field. We're delighted to have three esteemed colleagues on our panel today, Dr. Mike Garcia from GammaTile, Dr. Rupesh Kotecha from the Miami Cancer Institute, and Dr. Nick Avgeropoulos from Novocure. This team will talk today about a diverse approach to CNS treatment. And so I'm really, really excited that they're here today to join us. And so this session will use a case-based format, and audience participation is encouraged when we have poll questions or chat questions that come up. And so we encourage you to be engaged and ask questions. And we'll have 3 segments dedicated to different aspects of CNS modalities. If you have any questions, feel free to pop them in the chat along the way. And I will try my best to keep us moving forward. So we'll kick off this session with Dr. Garcia from GammaTile discussing a case. So I will get us started.
Thank you, Indu, and thanks to ACRO and Rover for having this panel and for inviting me to be a panelist. I'm honored to be a panelist with Dr. Kotecha and Dr. Avgeropoulos. I'll start with the first case. So I'm a radiation oncologist in Phoenix and the chief medical officer of GT Medical Technologies, which is the maker of GammaTile. And we'll go through a case of a particularly challenging situation, which is the management of a recurrent brain metastasis, a brain metastasis that has recurred after previous radiation. And next slide. Here are my disclosures. As I said, I'm an employee of GT Medical Technologies, which is the maker of GammaTile. Next slide. So this is a case of a 64-year-old woman with known metastatic breast cancer. In 2019, she developed some mild right arm weakness. She had a brain MRI to work that up, which revealed a 2.8 centimeter right frontal brain metastasis. Next slide. And this was managed with gamma knife radiosurgery, a single fraction of 18 gray and a single fraction. And I just included this table here just as a reminder for the residents in the audience. It's good to remember these numbers for the clinical or oral boards. And RTOG 9005 was a dose escalation study to understand what doses we could use a single fraction for brain mets. And out of that study came the understanding that we can treat tumors less than 2 centimeters with 24 gray in a single fraction, 2 to 3 centimeters with 18 gray, and greater than 3 centimeters with 15 gray. But the caveat, and it's important to know that for larger brain mets, really fractionated radiosurgery is now more commonly used, and the data is supporting that. Next slide, please. So that patient was treated with single fraction radiosurgery, and about 9 months later, in 2020, the patient was undergoing brain surveillance with brain MRIs every 3 months. But about 9 months later, in 2020, a follow-up brain MRI was done as part of that follow-up. And around that time, she noticed some recurrent weakness of the right arm. And that MRI showed that treated brain metastasis had enlarged to 4.3 centimeters, this ring enhancing, and there was significant edema. This was enlarged compared to the pre-radiosurgery mass that was treated with Gamma knife. So what's the differential diagnosis? Next slide. So this is not an uncommon dilemma. And the differential diagnosis includes an adverse radiation effect, such as radiation effect, or such as radiation necrosis. And the median time to adverse radiation effect, based on a large study from UCSF, the median time for this phenomenon is about 7 months, with 85% of cases occurring between 3 and 18 months. And the other thing on the differential diagnosis is progression. In other words, local failure of the treated brain met. Next slide, or next slide, please. And how do we differentiate between these two things? Again, this is not an uncommon situation, but it's a challenging one. Next slide. So a few ways. One is, if this is necrosis, you could treat that with steroids, and of course that would benefit the patient with the edema regardless from a symptomatic standpoint. And sometimes a tincture of time following on steroids can lead to us better understanding what's going on. If the enhancement in the edema improves, then that's probably necrosis. However, if the enhancement continues to worsen on steroids, then that could indicate true progression. Sometimes other modalities can be used, such as perfusion MRI. This looks at blood flow to the lesion. And typically, if it's a progressive lesion, there's going to be increased perfusion. And if it's necrotic, there'll be decreased perfusion. And then also obtaining tissue through surgical resection if felt to be appropriate. If the patient has symptoms and there needs to be rapid mass effect relief, then resection can be therapeutic, both for necrosis and for progression. And then that would give the definitive answer from a histologic standpoint. Next slide, please. So for this particular patient, the plan was made to treat her with steroids and have a short interval brain MRI within 2 months. But unfortunately, that showed continued enhancements. And she continued to be symptomatic. MRI perfusion was also done, which showed increased perfusion at the lesion, indicating progression. And again, she continued to have symptoms. Next slide. So here's the first poll question. How would you manage this suspected case of progressive or local failure with still necrosis being on the differential, although maybe perhaps thought to be less likely right now? Would you resect and then observe? Would you resect and then offer post-operative radiosurgery to the cavity? And this would be reirradiation because this area has been irradiated before with Gamma knife. Would you resect and use a different radiation modality, such as brachytherapy at time of resection? Or would you just do repeat radiosurgery without resecting? Or would you consider something else, such as LIT? So I'll let Indu decide when we should proceed. Okay.
Yeah, so I think for everyone, a poll has popped up. I don't know if, are you able
I can
to
see the results
it
of
as
it.
well?
And I'll read
Okay,
it out just in case people can't see it, but I can see it. So the two most common responses were resection and observe, 33%, resection and then post-operative radiosurgery, 33%, and then resection with brachytherapy, 22%, and repeat radiosurgery, non-resection, 11%, and then LIT was 0%. So the first A and B were the most common answers. And this is a very challenging situation. There's really no right or wrong. There's no true standard here. Next slide. So just a little bit of data in regards to those options. Based on, and there's not a ton of data here, but there are a number of institutional reports. So if this were to be resected and then observed without additional local adjuvant therapy, local failure rate is on the order of 40 to 44%. And there was a recent publication that just came out of MD Anderson, published in PRO a few months ago, that looked at, I believe, around 100 patients and who were observed, and local failure was 40%. The other option is resection and the postoperative radiosurgery. Local failure is better than with observation, but still not ideal, with local failure being on the order of 25 to 30%. This is based on reports from Memorial Sloan Kettering in Pittsburgh. And then resection with brachytherapy, cesium-131 specifically, 3 institutional reports from Barrow, Dr. Kotecha's group at Miami Baptist, and Barrow and Memorial Sloan Kettering and Baptist showed a local failure rate of 0 to 20%. Next slide. So this patient ultimately went on to have resection plus brachytherapy in the form of GammaTile. And I'll talk about other forms of brachytherapy, but brachytherapy has some theoretical advantages for recurrent brain metastasis that has been previously irradiated. You want to be able to dose escalate in a somewhat safe manner because you know that this tumor recurred after previous radiation, so it's showing itself to be radio-resistant as long as there wasn't a marginal failure or it was underdosed in some regard. But assuming it was well treated, well targeted with appropriate dose, it's a radio-resistant tumor, and therefore dose escalation makes sense. And you could accomplish that with brachytherapy because of the rapid dose fall off. You get about 150 gray to the surface of the cavity and then have rapid dose fall off. GammaTile is a form of brachytherapy that's cesium-131. There are these collagen tiles that are made out of duragen, which is what the neurosurgeons have been using for decades to reconstruct the dura. And each tile has 4 cesium seeds spaced apart equally by 10 millimeters. And these collagen tiles, when they're hydrated before placement, they become sticky because they're hydrophilic. And so they stick to the cavity and maintain shape. And so this patient had it. Here's the postoperative dosimetry for this patient. And you can see that the cavity wall got about 120 gray with low dose rate brachytherapy. And about 4 to 5 millimeters out, about 60 gray. This is low dose rate brachytherapy. So this is not the same as 2 gray per fraction to 60 gray. This is similar from, if you're looking at an alpha beta of 10, about equivalent to a 30 gray and 5 fraction course of radiosurgery, to put these doses in perspective. Because the cesium has a half-life of 9.7 days. So it takes about 5 weeks to get that full dose. Next slide. So brachytherapy has had these theoretical advantages, and in recognizing these, brachytherapy for the brain has been attempted in the past without a ton of success. Going back into the 80s and 90s, there was high-dose rate brachytherapy with I-125 through catheters, mainly used for glioblastoma. There were 2 unsuccessful clinical trials done. And as you can imagine, this was kind of a morbid procedure because using these catheters. And then Gliosite was attempted in the early 2000s, also high-dose rate brachytherapy through this balloon liquid I-125. That was also morbid, as you can imagine, and fell out of favor and is no longer commercially used. When I was in residency, we initially were doing I-125 seeds, but the problem with I-125 seeds is that the half-life is 60 days, and that was leading to high rates of radiation necrosis. And then, of course, if these seeds migrate and the half-life is 60 days, so it takes about it takes months to give the whole dose. If they migrate, they're still radioactive. And then later on, the field sort of migrated away from I-125 to cesium-131 due to the short half-life. And one way to do that is through these stranded seeds. The challenge there is placing these seeds apart perfectly from each other because you could end up with very hot spots if they clump or very cold spots if they're not spaced out perfectly. And then most recently as the advent of GammaTile, which essentially is the same as cesium-131, but it ensures proper spacing from one another. And then there's a 3 millimeter offset to prevent very, very high doses of radiation to the brain, which you can get, and I'll show in the next slide. So the issue with brachytherapy is you can have a high risk of necrosis. And that's, again, because the radiation falls off in a 1/r² manner. And when the seeds are placed directly on the brain, that can lead to very high doses of radiation. But by placing, next slide, by having a 3 millimeter offset, you can prevent those very, very high doses, such that you still get a good dose, about 150 gray to the cavity, but it's much less than if you place them directly on the brain. Next slide. So GammaTile is cleared for a few indications from the FDA. One is for newly diagnosed malignant brain tumors, and the other is for any recurrent brain tumor, such as a grade 1 or grade 2 meningioma. Next slide. And to date, around 1,200 patients have been treated with GammaTile. Miami Baptist is a high volume center. There's a number of high volume centers, but it's used in about 100 centers throughout the country right now. Mainly in the recurrent setting, and 85% of cases being done for recurrent glioblastoma, recurrent Mets, and recurrent meningioma. And we have some clinical trials for newly diagnosed, which I can talk about at the very end if we have time. Next slide. Here's the data that supports the use of GammaTile for recurrent brain Mets. The Barrow experience was the first, and this was pre-commercial, pre-FDA clearance, which showed a local control rate for recurrent previously irradiated brain Mets to be on the order of 80% at 12 months. So 16 brain Mets. It was a relatively small study. Memorial Sloan Kettering then published their experience on their tumor registry. So we showed a 12-month local control, about 92%. And then Dr. Kotecha's group at Miami Baptist showed a local control rate of 100% at 6, 12, and 18 months. And that their study was really interesting because they compared local control at these time points with the local control after the previously attempted radiosurgery. So using patients as their own internal controls. So these are particularly challenging patients, and they failed radiosurgery relatively quickly with a 6, 12, and 18-month local control rates of 66, 33, and 25%. But again, these patients were salvaged with re-resection and gamma time. Next slide. And then very briefly, for the sake of time, I'll just mention there's data for newly diagnosed Mets from the University of Minnesota. We have a phase 3 trial looking at gamma tau for newly diagnosed Mets called the ROAD study. And then recurrent glioblastoma and recurrent previously irradiated meningioma. There's data from Barrow and University of Minnesota. For the sake of time, I'll finish there. I will mention, I don't have a slide on this, we have 4 active clinical trials going on in these spaces for newly diagnosed Mets, comparing postoperative radiosurgery to gamma tau. It's multi-institutional phase 3 led by MD Anderson. We have an upcoming new recurrent GBM study called Pathways that'll be a phase 3. We have a newly diagnosed glioblastoma study that combines gamma tau with IMRT as a way to bridge the patient over to IMRT. And Memorial Sloan Kettering has an investigator-initiated trial for recurrent brain mets, and then we have a large tumor registry study. So that's all the material I had. Really appreciate everyone's time and looking forward to the discussion later and to the other 2 speakers' talks. Thanks.
Great. Thank you so much, Dr. Garcia. It's very interesting and I'm sure generating a lot of questions with exciting trials emerging. Next, we'll turn to Dr. Kotecha to talk about a case that looks at the management of multiple brain mets. So
Sure.
take it away, Dr. Kotecha.
Thank you so much for the introduction and for having me here as part of the panel here. So we have 3 cases here today covering 3 kind of different disease entities in the CNS space. So this will be a case of multiple brain metastasis and management. So next slide. These are my disclosures. I don't work in industry, but obviously have conflicts of interest to disclose. So see them here. Next slide. So a very brief background for this. So this is a 77-year-old lady with a past medical history of non-small cell lung cancer, diagnosed about 5 years previously. And then she presented to the hospital with headaches and a left-sided weakness. So with regards to her oncologic history, she had a stage 3A, T2A, N2 adenocarcinoma of the lung, for which she underwent a lobectomy and mediastinal lymph node dissection and 4 cycles of adjuvant carbotaxol. At that time, we didn't have, for example, the results of the lung ART trial, but she had deferred any adjuvant radiation therapy. On interrogation and molecular sequencing of her tumor, she had a KRAS G12C mutation, a P10 deletion, and a PDL1 of 80%. She had an MRI of the brain performed at diagnosis, which was negative for intracranial metastatic disease. And then she had been following with the medical oncology team for essentially the last 5 years and had restaging studies done about 1 month prior to her presentation to the ED, which were negative for any extracranial disease recurrence. Past medical history otherwise is really unremarkable. Next slide. So she had a CT of the brain without contrast on admission, which revealed 2 hyperdense lesions with surrounding vasogenic edema, as you can see here in these arrows we've placed. Next slide. And she subsequently underwent an MRI of the brain, and there were 6 enhancing intracranial lesions that were visualized. So I show these 3 lesions here, as you can see, marked and measured. And then these are the supratentorial brain lesions. And then the next slide has the infratentorial brain lesions, as you can see here, small in size, a little bit atypical in their appearance. Next slide. So this actually didn't make it out to a poll question. So for those who have the ability to put it into the chat, there are a number of next steps that we can consider in a particular patient such as this. We can move on to treatment options. That could be, for example, corticosteroids alone. You can do whole brain radiation therapy, either conventional whole brain, hippocampal avoidance whole brain, or things like memory avoidance whole brain radiation therapy. Surgery and whole brain, surgery and radiosurgery, whole brain and radiosurgery, not commonly done anymore in the upfront setting. Radiosurgery alone, systemic therapy alone, or potentially further workup. We need more information. So now we have a number of responses coming in the chat. So just think how you would approach this patient. Next slide. So for the interest of time, I'm just going to go through the rest of her workup. So given the atypical appearance of the infratentorial disease, we decided to complete the rest of the workup during her admission. So we did a restaging PET CT scan, which was negative for any extracranial disease relapse, consistent with her CT scans done a month earlier. We did MRIs of the entire spinal axis, which were negative for any disease along the spinal axis. We did do a lumbar puncture, and we found 37 tumor cells. And you can see here the PD-L1 was actually negative for the circulating tumor cells. Next slide. So now, faced with this information, maybe think to yourself, or you can put in the chat how you would either change your recommendation based on this information or keep with the same. So I think we've kept a lot of the same options. So corticosteroids alone, whole brain radiation therapy, surgery and whole brain, surgery and radiosurgery, whole brain and radiosurgery, radiosurgery alone, systemic therapy alone, and we've added another option here of craniospinal radiation. Next slide. So at our facility, as a research facility, we have a number of options for these patients. So essentially, when we see a patient, for example, with newly diagnosed leptomeningeal disease, essentially these are the kind of the four things that we think about that could potentially be offered to that patient. So we can do conventional whole brain radiation therapy alone, diagnosis of leptomeningeal disease, intracranial disease only. Whole brain radiation therapy has been a standard treatment option for these patients for a number of years. At least at our facility, we try and roll them onto a neurocog registry that we have. We do app-based neurocog testing in our patients. And then we also have a connectomics mapping registry that we're looking at connectomics features in the brain and how those change before and after whole brain. So that can be a potential option for the patient. Second option could be a phase 1 trial. So this is a trial that we have open at our center. It's a phase 1 study of a GDC 0084, which is paxilosib and radiation therapy for patients who have either brain mets or leptomeningeal disease. For those that have alterations in the PI3 kinase pathway, for which, as I mentioned before, the patient has a P10 deletion, so that's in that same pathway, would respond to such an agent. So that's a potential option for that patient. A third option is systemic therapy alone, right? She doesn't have a significant amount of intracranial disease burden. And the tumors themselves, most of them are less than 5 millimeters. So potentially consideration of pembrolizumab alone, given that she has a PD-L1 of 80%, which has been shown, at least in some series, both for brain metastasis as well as for leptomeningeal disease. It does have a PD-L1 that's negative on the CSF circulating tumor cells. You know, the influence of that, though, is still unknown. And then also there are KRAS drugs that are available on the market as well, as this patient had initial KRAS G12C mutation on the initial sample. Finally, proton CSI is now an emerging option for patients who do have leptomeningeal disease, typically for patients who have good risk leptomeningeal disease, but also for those typically that have more burden than, for example, this patient, and again, also eligible, for example, for neurocog registries. So these are the options that we kind of had available at our facility for this particular patient. She ultimately actually decided, after a short course of steroids, became completely asymptomatic. And this past year at ASCO, there was actually a abstract combining pembro and adagrasib in this patient population. And based on initial phase 2 results, she was actually able to be approved for that combination therapy. So next slide. So from a radiation standpoint, what are the options for these patients and what do we do? So as I mentioned, essentially we try and roll all of our patients onto a neurocog registry. We have an IIT for those patients. And then essentially for patients in the modern era who have good risk leptomeningeal disease, we have at least transitioned to start offering them proton craniospinal radiation, which is traditionally 30 gray in 10 fractions, and also have them meet with medical oncology to really optimize their systemic therapy to follow that. So next slide. This is our pathway, at least for leptomeningeal disease workup. So if somebody comes in with suspicion or potentially diagnostic for leptomeningeal disease, we do complete the rest of the workup from that initial radiographic findings. So MRI of the brain, MRI of the spine, restaging studies of the body, I think are going to be important to be able to discuss with the patient and the medical oncology team with regards to further systemic therapy, what options are available for that patient, CSF evaluation with molecular profile, And you can potentially see subtype switching, for example, in the breast cancer space. This is just an example of a patient who had a subtype switch between their primary tumor and their intracranial disease. Essentially, we divide patients into two pathways. The bottom pathway is really for symptom management for the poor risk patients. Those patients get transferred consideration of hospice and palliative photon and ball field radiation therapy. But for the good risk patients, as I mentioned, we've kind of transitioned to now offer them proton craniospinal radiation with neuro-onc follow-up. And that's MRI of the brain, spine, and CSF evaluations, both at diagnosis and then during routine follow-up. It's actually the first patient that I ever treated with proton craniospinal radiation. And you can see essentially pre-CSI, they had 41 tumor cells, and 8-week assessment post-CSI went to 0 tumor cells. So you can see pretty good responses in this patient population. Next slide. So we started doing this actually based on a phase 2 trial that was run out of MSK. In fact, actually, it was going to be a multi-institutional study. We were supposed to join this study, and then the DSMC closed it early as it was a positive study on their initial analysis. And so this is something that we actually had already thought about and done all the workflow at our institutions. Were able to enact this pretty quickly when we had the early results. In this study, there are patients who had other solid tumor histologies and exploratory cohort who were treated with proton CSI. I'll focus on this left-hand side. And patients who had non-small cell lung cancer and breast cancer were enrolled, stratified by histology and systemic disease status, and randomized in a 2-to-1 ratio to proton CSI 30 and 10 versus involved field radiation therapy, which is whole brain plus or minus any spine radiation therapy for any symptomatic areas. Patients are followed with MRI of the brain, total spines, and then lumbar puncture. And hopefully, as you can see, essentially our paradigm has kind of matched what the clinical trial data is. We are still collecting data, for example, in our patients. And it's a real world expansion cohort. So next slide. See the results from the trial at the interim analysis at the DSMC reviews. And the median CNS PFS was 7.5 months versus 2.3 months. And the median overall survival was statistically significantly improved. And this is pretty substantial in the leptomeningeal disease space. So 9.9 months versus 6 months. Data is actually going to be updated for more longer term follow-up for these patients. I think submitted to a meeting soon. Next slide. So this has actually led to a clinical trial as a confirmatory study. So this was actually a proposal, BN2225. So Jonathan Yang is the PI for this study. I'm on the study team, so we've been finalizing actually the protocol for this. This is essentially a study to confirm the overall survival benefit to proton CSI, which wasn't the primary endpoint for the original phase 2 randomized study. So these patients will be accrued if they have radiographic or cytological leptomeningeal disease, have a good KPS, reusable systemic therapy treatment options, obviously prior things like radiosurgery allowed, but not prior whole brain radiation therapy. They're stratified by histology, systemic disease status, and then also we've added in here the systemic therapy. Patients are randomized in a 2-to-1 ratio to proton CSI versus standard of care, which essentially could be any form of photon and ball field radiation therapy. So this was a concept and then got approved by CTEP, so it will be NRG BN14. This trial will be run also internationally, so hopefully it will accrue broadly across multiple countries. Next slide, and that's my last slide.
Great. Thank you so much, Dr. Kotecha. It was very interesting talk and a case-based presentation. We do have a couple minutes left in this segment, but perhaps we can move forward to the next case. And then at the end, we can have some time for questions across the 3 cases and our panelists. So with that, I'll give the mic over to Dr. Avgeropoulos from Novocure, who will be speaking about TTF in the present day. So please take it away.
Thank you. Thank you very much. And, congratulations to the previous speakers for really wonderful data. I'm a global therapeutic area lead. My first disclosure is that I'm not a radiation oncologist. I'm a medical neuro-oncologist, so that's maybe a different kind of a disclosure. Otherwise, I am employed by Novocure. And so if I may have the next slide. So the way I've set up this presentation is to maybe introduce briefly the case report and then talk about Tumor Treating Fields, mostly to get everybody on the same page in terms of familiarizing with the data, the major clinical trial information, and then going back to the case and finishing it up. This is a 71-year-old female, right-handed, high-functioning, mother of 2 grown children. As many times those of us who are treating glioblastoma patients, really not much medical history necessarily, or any independent risk factors for glioblastoma per se. The presentation was one of subacute onset difficulty, sending texts on the phone. You know, as many of us do, we second guess our memory. We second guess if we're tired. This progressed to dyslexia, and ultimately, because of the comprehension issues, she went on and had an evaluation. If I could have the next slide. And what we see is a heterogeneously contrast-enhancing mass in the left temporal lobe, more anterior, really. Looking at this, there was some vasogenic edema around it, but honestly, not too much sulcal effacement or you know, major mass effect that I think would require other urgent decompression or steroid decompression. I will jump ahead before showing the images of the postoperative imaging to say that the histopathology had an appearance of a highly cellular lesion that was glial. There was pseudopalisading necrosis. The IDH was wild type, and MGMT in this case was methylated. And so the imaging really matches up with the clinical picture. And then what we're looking at is a glioblastoma in the dominant temporal lobe. If we could have the next slide. So a standard of care for glioblastoma treatment is alternating electrical fields, or otherwise known as tumor treating fields. We could have the next slide. The NCCN guidelines, I've taken excerpts from them to discriminate the less than 70 years of age, better functioning patient population, newly diagnosed, versus greater than 70, again, with better functionality. And it's to point out that there are several standards of care. One is the so-called STOOP, or European protocol, with temozolomide-based chemoradiation followed by 6 adjuvant cycles. But also the addition in the adjuvant setting within the first 4 to 6 weeks post-chemoradiation for patients who had stable disease afterwards. The preferred NCCN guideline category 1 recommendation is to add alternating electrical fields. And that's a new designation as of earlier this year, that preferred designation. And that goes for both methylated or unmethylated or even indeterminate. In the over 70 years of age, that preferred status is not there. However, it's only one of 2 category 1 recommendations, one being hypofractionated with concurrent and adjuvant temozolomide. And the other, again, is the tumor treating field or alternating electrical field therapy. And in unmethylated, again, the tumor treating fields are there. So, you know, these are updates in the NCCN guideline recommendation. I think that they're important in the sense that that preferred categorization is now added. We can have the next slide. So what is the device? It's a class 3 medical device, which means that it's a device that's approved based on its necessity to be used for prolonging life in life-threatening conditions. Most of these are implantable, whether it's pacemakers or defibrillators or what have you. And this is one of the external ones, not the only one. Prosthetic devices of certain kinds are also falling under this category. What it is this roughly 3-pound, half of that is the battery, the lithium battery, and the other is the receiving and delivery end of the tumor treating fields. The tumor treating fields are designated, and I'll bring you for a walk over the visible spectrum, visible light spectrum onto the non-ionizing side for a few minutes, so you can see the 100 to 300, and specifically for glioblastoma, it's 200 kilohertz of frequency, and it alternates every 1 second. There is a treatment planning software that's the so-called Novotal, which is now being upgraded and in process of review through the FDA and other governing bodies. And it's positioned in these to optimize the fields in the area of concern. If we can have the next slide. So where do we get these data? Next slide. The EF14 is the pivotal study, and most everybody is going to be familiar with it. The indications are for newly diagnosed glioblastoma, 22 years of age and greater is on the label because that was the youngest patient who was enrolled in the study. And the contraindications, by and large, are fairly minimal, but any implanted devices that would, bullet fragments, things like this, or something that would be contraindicated with respect to adhesive gel allergies. Next slide, please. Next slide. I'll cover some of those a little later. So here's the nature of the clinical trial. So this is the largest study of glioblastoma patients that followed the STOOP study, which was a little over 600. This was 695, if I remember. And the subsequent ongoing study, now Trident study, that's taking this study and adding in one arm the Tumor Treating Fields device during radiation. That's going to be close to 750 or something like that, if I remember. That will be the largest study to follow. At any rate, the way that this study was performed, it's newly diagnosed, followed by maximum feasible surgical resection, then standard temozolomide-based chemoradiation. And then there was the randomization, and the patients were randomized 2 to 1. 2 would get adjuvant temozolomide plus Tumor Treating Fields, and then the 1 would get standard of care temozolomide. But the interesting portion of this clinical trial design is based on previous studies like the EF11, that there was a supposition that maybe there was some duration-related impact of this device. So the patients could stay on through first progression and up to second progression, or a cap of 24 months. And the stratifications were by extent of resection and MGMT. And now this is in the early 2010s, so we don't, we really didn't have the stratification necessarily of IDH mutant versus wild type, but in retrospect, those did balance out. The primary endpoint was progression-free survival, secondary endpoint, overall survival, and various other metrics. We can have the next slide. So just to cut to the chase, the median overall survival was significantly extended. You can see the numbers, the 20.9 months from the time of randomization and 24.5 months from the time of diagnosis. The numbers of patients allowed a strong statistical significance between these two groups to be determined. It was probably about 4.5 or 5 months different on this study. Next slide, please. And then the primary endpoint of progression-free survival similarly had a display of the curves that really didn't meet at the end of that. Next slide. What I find particularly compelling about Tumor Treating Fields, not to say that the rest isn't, is really when a patient comes to your office. I mean, one of the principal questions that somebody in the room, Scott, is, well, what are our chances of beating this thing, right? Glioblastoma is associated with a dreadful prognosis. And so looking here on this bar graph, that 5-year survivorship went from 5% to 13%. And of course, that was with a contemporaneous comparison within the study. Next slide, please. And another question is, if usage rates go up, is there a, kind of I'll put it in air quotes, dose response type of phenomenon. We see that once with the confidence intervals, once we get past 50% usage rates and upwards of 90% usage rates, we see a tumor treating field median survival going up. Now, perhaps the best part of this isn't written on the slide, which is that at a consistent 90% or higher usage rate over time, that the 5-year survivorship actually jumps to 29.3%, which, really in glioblastoma consistently is unheard of. And so I think that this is a very important point. And what about that subset? It was independent of other variables like IDH or MGMT. We can have the next slide, please. So here, once again, is perhaps a good way to visualize the independent stratifications and how tumor treating fields did on the left of the slide, or I should say the vertical line versus the right, and categorically methylated, unmethylated, age, older, younger, extent of resection, performance status, or gender or sex. Is none of those confidence intervals really touch the vertical line. And so if we can have the next slide. There was safety profiling done, and really the main event, going back to the slide with contraindications or adverse event profile, really was skin, because that's where the rubber hits the road. You've got the adhesive. You have to have care for it and be very diligent for it. And as an EF14 investigator myself, when I was a clinician, I have to say that I approached it like it was radiosurgery. There were these 9 transducers in the array. And because we put those leads on and saw the patients with these visits, we took care to find the exact spot where those were and put them on and on. So in terms of medical neuro-oncologists, probably the worst at understanding skin integrity, as opposed to our surgical and radiation oncology colleagues who are continuously meticulously looking at it. But of course, that's a learning curve, and that changed over time. The rest of these really washed out in terms of course, there's no systemic adverse event that's any different. If I can have the next slide. So to finish up the case study, next slide. I think this was to tee me up here, and then the next slide. Good. And so here's the post-resection cavity. And we see that essentially it was a gross total resection. The patient received temozolomide-based chemoradiation. They did not have progression after that. Next slide, please. And then they went on to receive temozolomide concurrently with tumor treating fields in the adjuvant setting. And that's where we leave our story. We see some ex vacuo change. We probably see some post-radiation gliosis to boot, going left to right over the splenium of the corpus callosum. And if we can have the next slide. And the adverse events, again, mild scalp irritation, fatigue during radiation, chemotherapy expected adverse events that were well controlled. Topical clobetasol was applied, and continuous, again, meticulous skin attention to skin was able to keep the patient on therapy. Next slide, please. And that's what I got. Thank you.
All right, thank you. Thank you so much. And we actually did very well on time. So thanks everyone for bearing with us. And we actually do have a good amount of time to have some discussion and open things up for our audience to ask questions with our panelists. So if there are any questions for the panelists, please feel free to enter them in the chat, and I'll be happy to direct those to any one of our speakers. Definitely a lot of really interesting content across the board, across different CNS sites, both primary and metastatic disease and emerging technologies. So if there are any questions pending, feel free to ask. I myself have a couple of questions, so maybe I can get the discussion started. And also, Dr. Garcia, I know you mentioned there may have been some additional information that you wanted to share about GammaTile, so we probably do have a few minutes for that as well, if you wanted to discuss anything.
Well, I think it was mainly just the available clinical trials, which I mentioned in that last slide.
Right. Yeah, that was actually super helpful to hear about. So thank you for bringing that up.
I did have a clinical trial question for Dr. Kotecha. For BN-014, if I recall correctly, arm 1 was the proton CSI arm, and arm 2 is the standard of care arm, non-proton CSI. So is it open to either radiosurgery or just whole brain? I assume whole brain, but because that's for leptomeningeal disease. So okay. So it's not like the case of like that you presented with brain mets with cells in the CSF. That's actually like radiographic apparent LMD on that study.
Yeah, so that patient, for example, could qualify for that study as, with brain mets and with leptomeningeal disease. They could enroll onto that study. They would be randomized essentially to photon involved field radiation therapy, which would be whole brain radiation therapy for that patient. And since they didn't have any spine areas, and they wouldn't get any spinal radiotherapy. So the randomization for that patient would be whole brain versus proton craniospinal radiation.
Understood. If the patient had a solid tumor that had a targetable mutation, would systemic therapy alone be allowed on arm 2, or would the patient again be mandated to have whole brain?
Yeah, it would be mandated to have some form of radiation to the brain.
Okay.
But it's a good question, yeah. So there's a question about VMAT CSI for palliative radiation in the context of leptomeningeal disease. I think that's a great question. And, there's been a lot of discussion since the data came out from the phase 2 study. So there was a phase 1b study that showed the safety of craniospinal radiation prospectively that then led into a phase 2 randomized study. The maximum tolerated dose or the safe therapeutic dose was 30 gray and 10 fractions. But the way the phase 1b was conducted, there was potential for dose de-escalation if there was a toxicity issue. There are toxicities that are encountered, but they were not an issue with regards to the full study. Photon CSI delivered VMAT or tomotherapy. There are a number of techniques that have been used. Is very challenging for patients, especially with leptomeningeal disease. They've typically received long courses of chemotherapy before, potentially have counts issues, and then photon CSI can potentially tank a lot of those and also cause things, nausea, vomiting, and symptomatic issues. And proton CSI is associated still with toxicity. We're actually just about to submit our experience to PT-Cog. We do have toxicities, right? We do have blood count issues. We do have GI toxicities, even with proton therapy. And with photon therapy, there's no prospective studies that have been published to date, no prospective clinical trials with photon CSI. There are some retrospective studies, but actually, if you look at the data for some of those, there's like a nice tomotherapy study, which is a very straightforward way of doing an IMRT type approach with photon therapy. And then you had a quarter of the patients that didn't even complete the radiation course. So not even completing 10 fractions of radiation. So because of tolerance issues. So that is one concern with photon CSI. When the trial went to CTEP, it was a decision actually from the Brain Malignancy Steering Committee to not allow photon CSI because of the potential toxicity and the lack of safety data in a prospective setting in the standard arm.
We have another question. So thank you, Dr. Kotecha, for that response. One more question for Dr. Garcia from an attendee. How difficult is it to implement GammaTile program if you haven't used it before?
Great question. So GammaTile is a very multidisciplinary modality. Certainly there needs to be neurosurgery, medical physics, and radiation oncology involved. And so certainly you'd want all those teams to be on board. And then hospital administration would also need to be on board. The team here at Gamma Tile, including myself, are happy to help walk through any of those steps to open a program. And we try to make that as easy as possible. It is a little bit of a difference in workflow and like understanding the number of tiles that needed to be ordered for each case ahead of time, and we're happy to help with that too. The gamma tile pre-authorization is different than a radiation procedure, in that the gamma tiles are purchased through the operating room and they are reimbursed to the hospital under the DRG code of the craniotomy hospitalization. And so they don't require pre-authorization the same do that like radial surgery or IMRT would. And so in that way, it's easier. And they're almost always approved when a craniotomy is approved. And it increases the reimbursement for the craniotomy because you're implanting a device. And so there are some steps, and it's mainly having hospital administration be on board, since the hospital would be purchasing the gamma tiles. But if you're interested, would love to talk with you offline about the process. And again, we try to make it as easy as possible.
Great, thank you. And another question for Gamma Tile team. Is the dose of Gamma Tile always the same, or can you change it based on the tumor?
It's a great question. Right now, they're always made to have a specific activity on the day of implant of 3.5 U. And that gives about a 150 gray dose to the cavity after the 3 millimeter separation, and also about 60 gray to 5 millimeters. Again, that's about equivalent to a 30 grain 5 fraction at an alpha beta of 10. So right now, they're always made that way. We could be open in the future to have different activities, but I think this has allowed us to study it the easiest, to have this sort of standardized activity. And so far, all the clinical outcome papers that have been published to date for METs, meningioma, and glioma have used that 3.5 unit of activity. This is in comparison to other forms of radiation or brachytherapy with cesium-131, the stranded seeds, or the individual I-125 seeds, where the activity levels could differ depending on what the specific physician would want, and really aim anywhere from the 60 to 80 gray at 5 millimeters, for instance. But I think this makes it a little easier for us to study it in a more standardized way. That's also all the activity, that 3.5 unit of activity is what's mandated in all our trials as well.
Great, thank you so much. I actually have a question for the NovaCure team about the skin toxicity. And I think because our audience can be diverse, from learners early in their training to those who are far along, I'm curious to know about how NovaCure helps teams with the skin toxicity management. And you touched a bit upon some of the basic management with like topical steroid therapy, or patients taking a break from using the TTF device. My own experience at Stanford is I've seen sometimes we refer patients to like a dermato-oncology clinic. Based on your work with different clinical groups, are there other approaches to guiding patients through the skin toxicity, and how long they can potentially take a break as well?
Yeah, thank you. It's a critical question, because it means patients being on therapy or not being on therapy. I mean, just the physical reality of it. And there's a paper for guidance by Lacouture, who is a dermato-oncologist out of Memorial Sloan Kettering, that has updated their guidelines in terms of approaches, whether it's irritation or infection or inflammation, or whatever that might be. There are some standard algorithms. You kind of brought up another point where different clinicians have different levels of comfort in terms of what their ABC or first steps are. And also different oncologists, radiation oncologists, medical neuro-oncologists have different access to dermato-oncologists or dermatologists who could be their partners. in this process, particularly in a community setting. So when I was in practice in Orlando, to find a dermatologist to, drop what they were doing to look at a scalp lesion and, recommend something to me. I mean, it was, first of all, just from a scheduling standpoint, but also just from their own kind of risk standpoint that, there's craniotomy, there's these are areas that are previously irradiated, steroid, operated denervation. And so those are complex problems that probably require sequential input. So, that's why the algorithms are there. But what we do very frequently as prescribers is through Epic or a secure channel. We'll share pictures. We'll help our nurse practitioners really take, the brunt of it. And they've kind of taken training and spoken with people through Novicure, but also with dermatologists to sharpen their skills. And then we use dermatologists secondarily, should there be something. Then there's always different techniques of how to remove these adhesives, how to rotate them, how to be diligent about those things, and education. So it's a bit of an amalgam without a set answer for so many different scenarios that occur, but nevertheless a critical piece.
Great. That's really good to know about. And I myself will definitely check out some of these algorithms as I see patients in the clinic. So I think that brings us to the end of our session. And thank you all for a really, really exciting panel covering a broad range of topics and technologies within CNS. We're really grateful to have your expertise. We're also really grateful for the sponsorship of this program from GammaTile and Novocure. So thank you so much for helping keep these sessions going and reach a wide audience. I just want to put in a plug for our next session in March, which will be focused on radiopharmaceuticals, following again a similar case-based format, but covering, I think, a really exciting and unique topic. So once again, thank you so much, Dr. Garcia, Dr. Kotecha, and Dr. Avrageropoulos for your time and expertise. And thank you to all our attendees as well. And wish you all the best for the start of 2024.
Thanks so much.
Happy New Year.
Okay. Happy New Year. See you all next time.